All right, everyone, I think we can go ahead and get started. We have a lot of information to cover today, so I just want to be sure we have time for everything. My name is Megan King. I'm one of the public health educators at the Washington Poison Center, and I'm so excited to have you all here today to talk about medications and falls. I am so pleased to be joined by our medical director, Dr. Scott Phillips. And Scott, how about you introduce yourself briefly?
Oh, thank you very much. And I appreciate everyone being here. So as Megan said, I'm the medical director of the Washington Poison Center. And one of our goals is really to provide a lot of public outreach. It's not just to answer emergency calls, but we do a lot of education. And so we have 3 public health educators that are just super, like Megan. And I want to specifically welcome all of our friends from Eastern Washington. I know we have quite a few, and particularly I'd like to welcome the people from Colville and Chewelah, small town from my home part of the country. So thank you all for joining us today.
Thank you, Dr. Phillips. All right, everyone, as we get going today, please feel free to ask us any and all questions. You can put those in the chat box or in the Q&A section. I will be monitoring them both, and I'll make sure that Dr. Phillips sees them. The session today is being recorded. I will send out the recording as well as a PDF of our slides and all of the many resources that we will be covering. You can expect that within about a week of today's session. So here is a quick overview of our agenda for today. We are going to dive in first to just the epidemiology of falls. What is going on across the country as well as here in Washington, and what are the factors that can lead to falls? We will then really take a deep dive into medications and falls and the link between the two of them. We'll cover some prevention tips specific to medication-related risk factors, and then we'll end the session today with a brief blurb on how the Washington Poison Center can help you all. Before I turn it over to Dr. Phillips to talk about the epidemiology of falls, I did want to provide just a brief overview of who we are at the Washington Poison Center. We provide a lot of different services all across the state, but our bread and butter is really this poison helpline, which is that 1-800 number you see at the top of the slide. You'll see it in every single slide after that as well. If you don't already have this saved in your cell phone, I encourage you to do so now. This phone number is free. It's always available 24/7 every day of the year, and it's completely confidential. We follow HIPAA laws as well. And if English is not your preferred language, we have access to interpretation in over 260 languages. You can call this phone number for yourself, for a client that you work with, for a family member, for anyone who might have been exposed to a potentially harmful substance, who might have swallowed something, come into contact with it with their skin, their eyes, any sort of way that they have come into contact to a potentially harmful substance. That could be medications, that could be chemicals, really anything. Our phones are answered by what we call specialists in poison information, or SPIs. They are all nurses, pharmacists, and poison information providers who've gone through a ton of training in poisons and toxicology to be able to help you all. All right, Dr. Phillips, anything to add before we move on?
Oh, I think the only thing is that 800 number is a national number. It's not just us, but when you call it, your phone call gets routed to the regional poison center that's associated with where you are at the time. So one number takes care of everything for you.
Perfect. All right, I'll turn it over to you then for the epidemiology of falls.
Great, thank you very much. Well, most often falls are a combination of many things. It's not always just a simple trip over a carpet or trip over a threshold. It typically involves a lot of things, and the older a person reaches in their lifetime, the more factors that add into the fall risk. And so we see this significant risk factors here surrounding the center, and it's difficulty with walking and balance, confusion, agitation, kind of neurologic things. Prior falls is one of the biggest risk factors for falls. Obviously, physical health issues like, bad lower back, knees, or hips are a problem, using assisted devices such as canes and walkers. Difficulties with incontinence are a problem just because there's some urgency and oftentimes people fall in relationship to that. But today we're really going to focus more on sleep medications, medications that make you drowsy, and in that will include alcohol as well, because it is a very common risk factor for falls in all age groups, but particularly in older individuals. Next slide. So the impacts of falls are not just a broken elbow. There's a lot of issues that go along with this. Now, the two most common things that we really worry about are closed head injuries, where you bang your head, and fractures of the extremities, arms and legs are common things. But there's also a lot that goes on with psychological effects. Leads to worries and distress in patients that they might fall again. Falls result in prolonged hospitalization because of all the comorbidities typically that go with this, and balance and required therapy to get back on track. There's obviously loss of independence because if you have a fracture, quite often you'll wind up in a skilled nursing facility or some other facility, or with loved ones in their home because it's no longer possible for you to take care of yourself. And then, of course, there's secondary complications such as blood clots in the legs or pressure ulcers if you're bound to bed for a long period of time. And surprisingly, survival rates, your ability to just keep living is really prominent. So if a patient fractures their hip while they're ill in the hospital, there's a 3 in 10 chance they will not survive, and a 1 in 10 chance of getting back to their previous level of independence. So 90% chance you're not going to get back to your level of independence. So falls have a tremendous epidemiologic impact on the elderly throughout the world. Next.
All right, so, oh, go ahead.
No, go ahead.
All right, so I'm guessing that probably every single one of you here today has probably known or has worked with an older adult who's fallen, and falls are just incredibly common, and that's what we're going to establish here in the next few slides. So this stat, we're going to start here with national statistics, and 1 out of every 4 older adults experiences a fall nationwide. But we can dive a little bit deeper into all of that on these next few slides. So the CDC put together this graphic, and it pulls all of this data from the last decade or so. And they say that an older adult falls every second. So that adds up to approximately 36 million falls every year. So then when you look at those who do fall, more than 8 million are injured. And those injuries lead to about 3 million emergency department visits and around 950,000 hospitalizations. So unfortunately, we also see around 32,000 deaths every year. So that human cost is just heartbreaking. There are so many lives that are just negatively affected by falls each and every day. But the financial cost is staggering as well. Medical costs for fall injuries total over $50 billion each year. So those costs are hospital stays, nursing home care, rehab, medical equipment, prescription medications, all of these different costs that all add up together. A lot of that cost is shouldered by Medicare, comes in around $31 billion, but also Medicaid as well as private insurance as well. All older adults are at risk for a fall. But as Dr. Phillips mentioned a couple slides back, some are at greater risk for others if they're seeing a combination of all of those different risk factors or a bunch of those different risk factors. We see on this graph, there are some different risk factors from what Dr. Phillips shared earlier. So these are some non-modifiable risk factors. So risk factors that we can't change, like our sex, our age, our race. This graph is also from the CDC, and it looks at the percent of older adults who have reported a fall. So we see that female older adults experience more falls than males. Falls increased with age, with the highest percentage being among adults who are 85 years and older. And there were also racial differences. There were a higher percentage of American Indian and Alaska Natives reporting having fallen than other groups. There are a lot of potential reasons behind racial and ethnic differences. I really encourage you to dive into some of the literature on it. I've included some study links when I send out the slide deck for you all. But some of those factors could be things like healthcare access or rates of chronic conditions, lifestyle, cultural factors like living with relatives versus living alone, how frailty is perceived, how falls are perceived, how they're talked about. So I encourage you to look a little bit deeper into that disparity. So what's the fall landscape in Washington? We are pretty much right on par with national statistics. So more than 1 out of 4 Washington older adults falls. That probably looks familiar. It's exactly what the nationwide statistic was. So there are over 1.1 million older adults in Washington. So that's a lot of older adults, a lot of our community members, a lot of our clients. We see the same trickle down in Washington, just like we do nationally. So of the 250,000-ish older adults who fell in 2019, there were over 14,000 hospitalizations that were non-fatal. And that cost our state around $1.1 billion. And then we additionally had close to 1,000 older adults die from their falls. So if you think those numbers are high now, we are just going to see more and more as Washington's age wave continues. So the percentage of our population that is older than 65 is growing very rapidly. By 2030, which is this graph over here on the right, our population that is older than 65 is going to be about 20% of the state's total population. And certain counties are going to have even higher percentages. So those are going to be the orange, red, and pink counties on this map. So when I look at these maps, it really just underscores how important the conversations are that we're having today and how important all of our work is moving forward. So before I turn it over to Scott, I just wanted to thank you all again for being here and for being a part of this work and starting to have this conversation with us today. Scott, any more comments on these statistics before we move on to medications?
No, I think again, that's, just the base rate of falls is really, really high. And so we have to keep in the back of our minds, since these are so common, what are we going to do that can modify it? How can we protect our patients, our loved ones who are getting up in years? And are there things we can do? Are there things we can modify? And we're going to discuss that a little bit further as we go along. So now we're going to talk a little bit about specific medications and groups of medications that put people at risk. And we had talked about unmodifiable conditions previously that Megan mentioned, but here we're really talking about potentially modifiable conditions. We saw before that age, chronic conditions, trip and fall hazards like rugs, ill-fitting shoes, perhaps small animals, assistive devices, even the fears. But we're really talking about substance use and medications. Those are common contributors to falls. So let's look a little further. So in the Washington Poison Center, so far this year, looking at patients 60 years of age and older, we've had about 5,000 medication types of calls in this age group. And you see the vast majority are medication errors, followed by medication accidents, intentional medication usage. In other words, essentially think of that like an overdose. And then adverse drug reactions, where it's not expected, but it happens from combinations of drugs and that kind of thing. Well, I think it's really important. It's like, well, that's not a large number, but if you look at this, there's some things that just really jump out at you. One, these are potentially preventable or at least modifiable, and we could reduce the numbers. But I think one of the things that's striking, that we've seen some other data that we've looked into, and we look at this every year, and that is overdoses in the elderly. So in this intentional exposure category, this is about 12% of these calls in the 60 and plus age group. I think that's quite a remarkable number when we're talking about the elderly. And it's certainly something that we can pay attention to and perhaps modify. So next slide. So what kind of medication errors are we really talking about? Well, there's kind of several wrong things that can go wrong, right? The dose can be incorrect. The medication can be incorrect, and that might be wrong medication, wrong combination of medications, wrong person's medication. It can be the person taking the medication can be wrong. It can be the time of day medication was taken is wrong. And it can be the way the medication was taken was incorrect. So there's several possibilities of you mixing up medications. And of course, the more cognitively impaired you are, whether that's just from, say, a mild dementia or a medication or alcohol, the more likely you are to make these errors. Next.
The only thing I want to add here is that these blue boxes, those are the most common reasons that we see in older adults. So primarily double dosing, followed by other forms of wrong dose, then wrong medicine and wrong person.
So here's a breakdown of those categories: wrong dose, wrong medicine, wrong person, wrong time, wrong way. Again, based on our data here in Washington. And the most common thing is the wrong dose. Most commonly for us, that means a double dose of medication. A person forgot they took their medicine and then they took another dose, or they took the wrong medicine or the wrong person's medicine. Those are the most common things. So there are things we can do to help people with taking the wrong medication or the wrong dose of medication that we'll talk a little bit about later on. So if we look at the most common substances for medication errors that resulted in a call to the Washington Poison Center, these are the top 5 hitters. And it's interesting because if you look at these, it's really not surprising, right? These are all medications you might find in someone with cardiovascular disease or people that have had strokes in the past or prevention of strokes. Beta blockers are medications that are like metoprolol and carvedilol and some other medications like that in the category. There's about a dozen of them. And they slow the heart rate down and they lower your blood pressure. Then the anti-hyperlipidemic medicines, those are medicines that lower your cholesterol that can cause some adverse reactions. Most commonly we see that is muscle weakness from what we call the statin medications that lower your cholesterol. The next category is the calcium antagonists or calcium channel blocker medicines. These are things like amlodipine and diltiazem and verapamil and several others. And they slow the heart rate down as well, but they also dilate the blood vessels, which can lower your blood pressure. So slow your heart rate and lower your blood pressure. That's a recipe for fainting and falling. The last 2 are medications that work in the kidneys, typically prescribed after a heart attack or for initial blood pressure control. And they are often associated with a little bit of lightheadedness and fainting episodes and can contribute as well. So next. So age-related changes. It's important to think about, why is it that elderly are at risk? Well, the answer is that we're constantly changing. From the time we're born to the time we pass into the great beyond, our bodies are changing. So our kidney function is changing, the amount of water to fat ratio, the body fat ratio changes, and that makes a difference on how much concentrations of medications are existing, either in the water, the body water, or the body fat. And then metabolism changes. You might metabolize things a lot slower. So you have a tendency to build up these medications if they're not adjusted in the dose property, much like kidney function. If the medication is not adjusted appropriately for your kidney function, those medications can build up and then result in more serious side effects. So these predispose patients to more interactions, to more side effects, and ultimately their chances of falling. So just aging predisposes you to these fallings where, again, up to 1 in 4 people have a risk of falling. So how do these medications impact, how do they contribute to falls? Well, they can result in cognitive impairment. And cognitive impairment simply means that you're a little foggy. You're not thinking clearly as you should. And that sometimes you see that in patients with a mild dementia or even a severe dementia. They just can't process information well, and you're just a little foggy. They can also result in gait and mobility impairment. And gait impairment means as you're walking, you're not walking smoothly. Your balance is off, and your walking, your stride is off, and you're at increased trip and fall risk from that. And we mentioned cardiovascular effects a minute ago with those top 5 medications, with low blood pressure, with being dehydrated from some of the diuretic medications, slow heart rates, fast heart rates, and something we call orthostatic hypotension, which is a fancy word that means your blood vessels don't respond normally as they should as you're going from a lying to a standing position. So it's really common for people to get up out of bed, get up out of a chair, get up off the commode, and get very lightheaded. Or you may have experienced that yourself, where you bend over to tie your shoe or stand up quickly and you get a little lightheaded. And that's an orthostatic blood pressure change, we call it. And of course, combinations of all of the above, which certainly happens frequently. And the older you get these combinations. And that's why we see increased risk the older you get in that one graph that Megan showed us early on. So polypharmacy is a fancy term we use. It just really means several drugs. So over 80% of adults between the ages of 60 and 79 use 1 or more prescription medications. And about 45% use 5 or more. And quite a staggering number used, I think, 12 or more. It's still in double-digit percent-wise. It's really striking. And so the more medications, the greater risk of interactions of those and the greater risk of side effects. So lots of medications, the more risks of falls. Well, I want to break down kind of categories of medications. And the first is just a general category we'll call sedatives, things that make you sleepy. So medications and alcohol that can make you sleepy. And these are medications like benzodiazepines, which is like Valium or Xanax or Klonopin, and muscle relaxants like Flexeril and Soma and Robaxin and Tizanidine, Xanaflex, and some others. Barbiturates are still around and they're still used and abused, but not nearly as much as they used to be. And of course, alcohol is still heavily used and abused, even in the older population. Well, I like this slide because this is specifically about benzodiazepines. So this figure with the different colors here represents the reasons why people took benzodiazepines. And it's really interesting. If you look down that list, you see the top pink area, the largest category is, well, we just wanted to relax or relieve tension. That's common, right? And that's very common with alcohol. 5% of the group, almost 6%, were experimenting. 11.8, almost 12%, were trying to get high. A little over 22% were just trying to help them sleep, and 10% with emotions. And then a small percentage to alter the effects of other drugs they're taking. And then a small fraction, just no reason. So it's really common for people to self-medicate off prescription with these medications to help them relax, relieve tension, and to help them sleep. So next. Now, opioids is a boy, it's really a hot topic for us at the Washington Poison Center, for health departments, for paramedics, emergency departments, hospitals. Everybody's in the boat on opioids and opiates, and it's important to think about them. Well, it's a problem for elderly, particularly if it's a new prescription to them or if it's chronically used by them. And the reason the chronic use is a problem is because that people will develop tolerance to opiates, so they have to take more and more and more, larger doses to get the same effect, and ultimately wind up with these episodes where it's unintentional overdoses. They just keep taking it to relieve their pain, but they wound up taking too much. Well, it becomes a real problem if you mix this category of medications, opioids and opiates, with medications that are sedatives, like we talked about, like Xanax or Valium or Ativan or those kinds of medicines, because it's more than an additive effect. This combination of medications is what we use in the hospital to put you to sleep to do certain medical procedures. So combining this medicine is no joke. It's really serious business when you mix these two together. This is what we call conscious sedation in the hospital, and should be done in the hospital. So it's also important to think about kind of non-traditional opioid medications, and we've seen a lot of use in recent years with anti-diarrheal medications like loperamide and diphenoxylate. And those medications are specifically to help people that are having diarrhea. But they're also opiate derivatives or opioid derivatives, and they can oftentimes be abused, and people will take oftentimes several hundred pills a day in order to maintain their habit. Well, I want to draw your attention over to the graphic on the right side of the slide. Now, again, this is a slide looking at the main categories in 60-plus-year-old people. And this is looking at suicide, intentional misuse, abuse, a therapeutic error, or withdrawal from the medication. And I think the important slide or the important column we see here is that there was a 19% increase between 2019 and 2020 of therapeutic errors in the elderly. So not only, as I pointed out before, is there an increased risk of suicidal harm, which we see the second largest category, but the largest is in therapeutic errors. And therapeutic errors are wrong medicine, wrong dose, wrong person that we mentioned. These are things that are modifiable. So let's jump down to the next category. So psychotropic medications is really a broad term for any kind of medications that alter the sensorium or alter your brain function, with the exception of the sedatives and the opioids that we already talked about. And really here we're talking about antipsychotic medications and antidepressant medications frequently used in depression, bipolar disorder, and situations like that. And these drugs can be very commonly referred to as, for antipsychotics, they can be quetiapine, Seroquel, they can be olanzapine, Zyprexa, or they can be sort of atypicals like trazodone and mirtazapine. The more common antidepressants are some of the old traditional antidepressants like amitriptyline or Elavil, nortriptyline, imipramine. More commonly, though, we're seeing a different category of medications called serotonin blocking drugs or serotonin receptor inhibitors, or serotonin norepinephrine receptor inhibitors, the SNRIs. These are newer medications that most people are starting on initially for depression. And MAOIs are quite older medications. There are some newer ones, but these also have very powerful effects. And most importantly, they have very powerful interaction effects that we have to worry about in contributing to falls and altered sensorium. Next slide. Okay, the cardiovascular drugs, we mentioned these a little bit before in our top 5 hits. And these includes vasodilators, which are medications that dilate the blood vessels, both the veins and the arteries. Diuretics, which make you lose extra body water by urinating more frequently and more quantity. Alpha blockers, which are blood pressure medications that also dilate the arteries primarily. And nitrates, which are things like nitroglycerin that you may have heard about, and a lot of derivatives of that. And those primarily dilate the veins and some the arteries as well. So all of those things contribute to lowering the blood pressure. Well, the next category is the heart rate. And here we see the calcium channel blockers, the beta blockers, medications that control extra heartbeats that are called antidysrhythmics, and digoxin, an old medication. All of those medicines can slow your heart rate. And if your heart rate is too low, will make you lightheaded and faint, likely to faint. And there's a way of measuring fainting by low blood pressure, and it's by measuring the orthostatic blood pressure. And Megan has been so kind to put a graphic here from the CDC on how to measure orthostatic blood pressures carefully. And this is really important when we're trying to decide about continuing medicines or discontinuing medications and whether someone is lightheaded or not, or at risk of fainting. So next slide. Well, not surprisingly to us, because we see an awful lot of adverse effects from cannabis at the Poison Center. But in older patients, more importantly, you see more coordination and cognitive impairment, as well as some medication errors. And this can be with more edible formulations or even smokable formulations. And with interactions with other medications can alter your blood sugar level and have some mild blood pressure lowering effects as well. The graphic on the right, I think, is interesting. It takes us from 1995 to 2019 on the horizontal axis. And if you look at that red line that goes diagonally upward through the slide, those are the percentages of THC in cannabis samples that were seized by the Drug Enforcement Agency between 1995 and 2019. So you see a significant increase in the concentration of THC. The blue line is CBD concentrations, which essentially are sort of in a seesaw kind of pattern and haven't changed nearly with the rate that THC has changed. So next slide. So we'd be remiss if we didn't specifically point out alcohol. And for those of you that are our pre-hospital providers or may work in emergency departments, you're very familiar with seeing people that are intoxicated from alcohol and have fallen. This is an interesting slide looking at different types of injuries of different body parts along the bottom, the horizontal axis, and the percentage on the vertical axis on the left. And the dark boxes represent cases with alcohol use, and the gray boxes are patients that had no alcohol use but the same injury. So you can see in the first two categories, alcohol plus or minus with head injuries, where it's at least a doubling of head injuries with alcohol, almost a doubling of face injuries. Upper extremity injuries, there's actually more in the control group than with alcohol, as well as in lower extremities. So if we really study the slide, the things that are interesting is with alcohol falls, you primarily injure your head and face. And that can be very devastating, particularly in the elderly who may be on blood thinners or aspirin or have other risks of bleeding into their brain. So next slide. Well, Mark Beers came up with a set of criteria about 25 years ago is when this first appeared. And these have become known as the Beers criteria. And the Beers criteria review medications and the risk of adverse effects of those medications. And since that time when Dr. Beers came up with this listing, It's been really taken over by the American Geriatric Society, and they update this list every 3 years. And these might be medications that affect your heart. They may have interactions, or they may be fall risk inducing medications as well. And so the last update of this was in 2019. And it's an important list to do. And it's actually a very, very long list of medications. And perhaps the easiest thing to do is just Google Beers criteria, even an image search, and it'll bring up these long tables of all the different medications that might be at risk. And you can compare those with your patient's medication list. So next slide. So medication errors and falls. Well, we know the wrong dose, the wrong time. They can have increasing or longer lasting side effects. There can be increased confusion. There can be more evidence that they're acting, less alert. They have lower blood pressure, or they're orthostatic. And these sedating effects can last longer. For example, like decreased metabolism from their liver. Well, there's also the wrong medicine, wrong person, and wrong way. And this can lead to new side effects, can lead to drug interactions and interactions with existing medications. Next slide. So prevention. Well, I like to think of prevention in 2 different ways. Primary prevention, in other words, before the fall, and secondary prevention after the fall. Because remember, the biggest risk for a fall is previously having a fall. So primary prevention, we think about avoiding medications that might place certain patients at risk. For example, if you have a Parkinson's patient that's complicated by psychosis, you want to be very cautious in avoiding many of the antipsychotics and even some other sedating medications, because it really puts them at a greater risk of falling. So you have to really be aware of that and their stability, and that's sometimes best assessed by a physical therapist and occupational therapist, their real fall risk. Another medication that's commonly used is tramadol. And tramadol is a pain medication that's an opioid derivative pain medication, but in reality, pharmacologically, it's also more of a serotonin reuptake inhibitor medication. So it has a lot of adverse effects. It can lower your sodium, and lowering your sodium makes your ability to stand and balance and walk get quite impaired. And so falling is very common in people that have a low sodium or low salt levels in their blood. And again, combining opioids and benzodiazepines or medications that are called gabapentinoids, which are medicines like Lyrica and gabapentin, are commonly used, but all these medicines increase the risk of respiratory depression, increase your risk of decreased cognitive ability, and are really strong predictors of fall risk. So next slide. Well, secondary prevention and deprescribing, we call it. So first of all, deprescribing is basically trying to thin that list of medications the person is on, and it might involve many people. The pharmacist that's taking care of the patient, the nurses taking care of the patient, the doctors that are taking care of the patient, and of course the Washington Poison Center is here to help you work through that as well. And as we talked about before, second falls are very high after the first fall, and so you don't want to miss this opportunity to intervene to deprescribe. Next. So let's talk about medication and falls. So this is a great question of patients. So asking the patients in the last 12 months, who's talked to you about medications that might make you fall? Most commonly, it was no one. 82%. No one talked to them about fall risk and medications. When they did, 15% was a physician, 8% were other healthcare providers, and 3% for family members. Well, I'd really like to think we can do better than this. if we just look, as we did very early on in this lecture, about the economic impact, this is an incredible opportunity to help people, to help their suffering, and to save a lot of healthcare dollars for other reasons in the state. Next. So one thing we recommend is at least every year, and maybe even more frequently, provide a medication review. Look over all the medications, look over all the indications. Patients frequently will get their medications from multiple medical providers and from multiple sources. So, and this needs to be comprehensive. You need to think about prescription medications, over-the-counter medications, supplements, even dietary diets, for example, that someone might be on. For example, a low sugar diet, or a high protein diet, or a low fat diet. All those can impact the way that medications will work. But it's important to utilize pharmacists in this because they really study this and have a lot of expertise in understanding these interactions, and seem to have a lot more time in going over these. And every time a patient comes into the hospital, it's an opportunity to review their medications when they come in, to modify their medications while they're there, and to de-prescribe medications, and to send them home on fewer medications. And that's often something that I'll teach my residents, is that with every hospitalization, your goal is to remove at least one medication, hopefully one medication a day, but always send them home with fewer medications if possible. So the next. So we want you to review all prescriptions and the over-the-counter medications and vitamin supplements, diets, etc. And our opportunities here are stop medications when possible, switch to safer alternatives, and to reduce medications to the lowest effective dose. So this is really deep prescribing. Stop them, switch them, and reduce them. This is really important. And this is part of implementing a good medication management strategy. Next slide. So stop medications when possible. Try to confirm if they're still needed. Oftentimes medicines just get carried on and on and on without a real review of them. Look for drug interactions, and most of our electronic medical records in hospitals and pharmacists are very good about flagging drug interactions that exist. So it's important to pay attention to those. And always remember to ask about substance abuse, like alcohol. Next. And switch to safer alternatives. That might be one that has fewer side effects or fewer interactions. It might be changing an older antidepressant to one of the newer ones with fewer side effects and fewer risks of falling and fainting. And also think about the psychological status of the patient in prescribing. For example, there's some very dangerous medications that you may not want to prescribe to patients that have demonstrated that they're really not able to make really good decisions about how they'll take their medications appropriately. For example, methotrexate is a medication we take weekly. Oftentimes we see it taken daily, and that can result in some devastating bone marrow suppression and death in patients if it's taken incorrectly. We also worry about dementia and suicidal risk in these patients, as we talked about earlier. So switching to safer alternatives, making these harmful medications or higher risk medications less available is a good thing. So next. So reducing medications to the lowest effective dose, de-prescribe them, dose reductions. You know, there's some great data out there in many parts of the world. There's two studies in particular I really like that were done in Singapore in 2019 and 2021 that looked at patients in skilled nursing facilities, kind of the equivalent in Singapore. And this was done out of Tan Hock Hospital in Singapore, a very large hospital there. And they found that by doing a comprehensive medication review and management of these patients, both in the hospital and in these skilled nursing facilities, they could reduce fall risk by 26%. So that's striking. So paying attention to medications is a huge factor in reducing morbidity, and it's also a very significant cost savings. Next. Megan, you want to take this?
Sure. So we have just thrown a lot of information at you, and definitely don't think you're going to remember all of this or be able to just right off the bat work on all the recommendations that Dr. Phillips just had. But thankfully, there are a lot of really great tools out there that you can turn to help you through this process. So one of the primary tools that we reference here is the STEADY program, which is through the CDC. STEADY stands for Stopping Elderly Accidents, Deaths, and Injuries. So this is a program that's designed for healthcare providers to screen their older adults, assess, and intervene where necessary with their fall risks. So it doesn't just focus on medications. However, there is a section that is specific for pharmacists and how pharmacists can intervene with their patients and help with their fall risk. So there are a lot of different clinical resources that are available. There are assessment tools, algorithms, all sorts of different things that you can use for inpatient care, outpatient, pharmacy care, all over the board. And then there are also some patient and caregiver resources that providers can use to distribute to their patients. We also reference here UNC School of Pharmacy has a really good high-risk medication recommendation guide. So I encourage you to take a look at that as well. And that is specific to older adults. Okay, so we are now going to talk a little bit about medication management strategies and things that you can recommend to the older adults that you work with to help decrease falls on their end. So this section is going to include a lot of resources that the Washington Poison Center has developed that are free for all of you to use. I will be sure in the follow-up email that I have included PDFs of all of these resources. They're also uploaded on our website, so you can go and download them from there. So this very first resource is a guide that has 10 questions on it that an older adult or a caregiver can use to talk to their healthcare provider or their pharmacist. They can use this guide if they are prescribed a new medication or if they're just curious about learning more about what specifically they're taking. These are really good discussion points for helping them know the side effects to expect, why they're taking a particular medication, if they need to potentially alter some of their other medications as they're on the specific medication. And it's a really good way for a provider and for a pharmacist to make sure that the older adult has a solid grasp on what they should expect, how to appropriately take the medication, and what could potential concerns be that they need to look out for or to talk to you about. We also have medication list development guides and templates for people to use. So it's really important for older adults to have a comprehensive medication list. Dr. Phillips talked about reviewing a list with folks at least on an annual basis. And we encourage people to just always have a list ready to go of all of the prescription medications they take, all of the over-the-counter meds, any vitamin supplements, or other substances that they use. So that could be cannabis if they use THC or CBD regularly. We do have a development guide if the older adult that you work with doesn't have a medication list already. It is a several page long guide that you can sit down with them and go through all of these different questions to write out a list together. There's also a version that an older adult can use to create their own. Dr. Phillips, anything to add on medication lists?
Well, I think this is important. The other thing I would add on is to make sure you bring this with you to each visit. Now, the hospital or clinic medical record typically has a list of these, but if you're getting medicines from different sources, they're not always synchronizing from one entity to another. So it's important to try to bring this with you every time once you've gone through it and filled it out, and make sure that they review it. Ask them to review it, the provider or go to your local pharmacist and even ask your pharmacist.
It's also really important to encourage the use of some sort of physical tracking system. So this can take a lot of different shapes and formats depending on what the older adult needs and how they can best work with something like this. So there are simple medication checklists. This is something that we provide at the Poison Center, where you would just write down the medication's name and then check it off after you've taken it. This format isn't the best for everyone though. You can use a phone calendar, a wall calendar. There are tons of cell phone apps that are out there that are free. This specific one is called MediSafe, and it's a free app that will give you pop-up alerts on your phone and just make sure that you're taking your medications on time. Pharmacies can offer support as well by bubble packaging doses. Not all of them will do this, but you can reach out to your local pharmacy to see if they do. People can also use pill organizers, and those will also range in the level of support that they can provide. What we have here on the slide is a very simple pill organizer, but there are some that offer additional support like audio cues or flashing lights. Some of them will lock until it's time to take the medication. Some of them will even contact you, the older adult or their caregiver, if medication hasn't been taken yet. Anything to add about tracking systems?
No, I think that's an important tool that is helpful in many patients.
And then it's really important to get rid of any unneeded, expired, or unnecessary medications. So we see a lot of wrong person, wrong medicine errors because of meds that have been kept. They're left over, they're not needed anymore, and someone accidentally takes them or purposefully takes them in some cases. So Washington has a really amazing system to securely dispose of medications. We at the Washington Poison Center run this website, takebackyourmeds.org, which you can go to and you can use this map function, or you can search for your city or county to see where different secure medicine return drop boxes are all across the state. Oftentimes, these drop boxes are located in pharmacies, grocery stores, other community locations. Sometimes they're in sheriff or police departments. All of these little green dots that you see with envelopes, those are places that you can go and get mail back envelopes from. So that could be like a local library where you can go pick up an envelope, put your expired medications in there and mail it back. Anything else here, Dr. Phillips?
No, I think this has been a great program for the state of Washington, and I would really encourage everyone to use it. It's very important. And it's not just for prescriptions, it can be for non-prescription drugs as well.
Yep, exactly. Other basic recommendations to share with your older adult clients or patients is to always, if possible, store their medications separate from other household members or from pets. You can't imagine how many calls we get of people who accidentally take their pet's medication. If it's not possible to keep medications stored completely separately, you can use some sort of easily identifiable visual differentiation between medications. So we have here these bands, colored bands you can put on bottles. It doesn't have to be that fancy. You could color the caps. One person has all blue caps, one person has yellow. You could use rubber bands, stickers, really anything that's really quickly identifiable. There are also a lot of different colored pill organizers that are available, which would do the same job. Final recommendation here is to safely store all medications. Recommend that all medications are kept out of sight and out of reach. If there are any children that might have access to the home, or if there is an older adult with dementia, this can be important for them too, to have those meds out of sight and out of reach. Locking up medications can be very important, especially if they are high alert meds like opioids, cannabis, sedatives, or antidepressants. We realize, though, that this is kind of a tricky thing to recommend with older adults because there is research out there showing that locking up medications can decrease medication adherence. It makes it less likely for an older adult to take their medications on time, to remember to take their medications. That's why it's so important to use some of those other medication management strategies, those reminder systems, to make sure that everything is being taken correctly. Anything to add here, Dr. Phillips?
No, I think that that really covers it well. I think one of the problems, if you look at the picture of the Locomed box there, the Locomed box, it has a small dial. And oftentimes, as Megan was saying, in older patients, particularly if they have a little cognitive impairment or bad arthritis, it's very difficult for them to run a combination lock. So there's kind of no one system that fits all. So you really have to have an open mind. And pharmacists in most of your retail pharmacies have a pretty good idea on this, or if not, we can certainly try to steer you in the right direction if you call us.
Great, thank you. Last thing here, I'll let you talk about this, Dr. Phillips.
Substance abuse. So, it's important to talk about it with your patients. Doesn't matter if they're older and you might think, well, this 70-year-old person doesn't use, drugs or alcohol, but you don't know that until you talk to them. And it's quite common for older patients to trade medications with one another, to use sort of off-label indications, to sort of create this wrong med, wrong person, wrong dose scenario. So you need to talk about it. You need to bring it out in the open. You need to ask them, are they taking their prescriptions? Are they taking any other medications from any other person or other source? Are they going to get their medications in Mexico? Are they going to get their medications in Canada? Are they getting medications online that are not kind of from reputable sources? And you also want to include these substance abuse issues on the medication list so you can quickly tell if there's potential for drug-drug interactions. It's very important. So remember, we have this 1-800 number. It's nationwide. If you're in Washington, you come to our call center here, 1-800-222-1222. And it's for information and for exposures. If you think you've taken the wrong thing, the wrong medication, the wrong dose, you don't know what you took, you're having symptoms you can't explain, please give us a call. We're happy to help. And it's not just for medications, it's also for plants and berries and shellfish and all kinds of things we take calls about. So if it's not clear to you and what's making you feel ill, please feel free to call us.
All right, and we encourage you to download any of our resources that we have available. They're always free. You can also reach out to me if we have a resource that sort of fits your needs, but might need a little bit of tweaking to better fit them. So just go ahead and reach out, and I'm happy to work with you to create something that will best suit your needs and your clients' needs. One of the resources that we did not talk about during this presentation, but is available to older adults and caregivers, are assessment guides for medication management. We have two versions. One of them is a self-assessment for an older adult to take themselves. The other one is built more towards caregivers or a family member or a friend who wants to take a look at the practices of an older adult in their lives. So these these assessment guides will walk through lots of different medication management practices, the environment of a person, and we'll make recommendations as to how that person could improve their taking of medications, making sure that they are safe and effective. We provide a lot of free educational programming at the Washington Poison Center as well, to older adult audiences, to caregivers, really any sort of audience, to organizations. We can cover a lot of different topics. We can focus just on medications and medication management, but we also dive into older adult substance use as well, including cannabis and opioids. So if you're interested in having any of this education at your organization, please feel free to send me an email, and I'm happy to connect with you on that. And that is all that we have for you today. It is 4 o'clock on the dot. Perfect finish. So if you have any questions, we can stick around for a couple minutes. Otherwise, thank you all so much for coming here today and for joining in on this discussion.
Well, it doesn't look like we're going to have much in the way of questions, and I want to extend my thanks to all of you who stayed to view this today, and we will send it out to you, as Megan mentioned, and upload it to YouTube so it will be available for others to see as well. So really want to thank you all for joining in and seeing our program today, and please call us here at the Washington Poison Center if we can be of any help to you.
And thank you, Dr. Phillips, for sharing your very valuable time with us today.
You're most welcome.
All right, everyone, I'm not seeing any questions, so I'm going to go ahead and end the meeting and be on the lookout for a follow-up email in the next week or so.